Pala was speaking very highly about you.
Sir, are we live on YouTube?
Yes, just a sec.
Okay, now it's in progress.
Yeah, we are. Good evening to all delegates. We are live on Zoom as well live on YouTube. Dehradun Obs and Gynae Society with Genetic and Fetal Medicine Committee, FOXY, presents a beautiful topic, Curbside Clinics on Prevention of Autosomal Recessive Disorders. So with this, I hand over the session. This is Ranjit Sahu, Marketing Head with Waterbusne. Welcome you to this beautiful topic where the esteemed delegates will be talking about. With this, I hand over the session to Dr. Vishal to take it forward. Vishal, sir.
Good evening, everyone. I am Dr. Vishal Wahane, working as Senior Medical Advisor at Walter Bushner. At the outset, Walter Bushner expressed gratitude towards Dehradun Obs and Gynae Society for giving the opportunity to organize this webinar. I take this opportunity to welcome the chief guest of honors, chairperson, speaker, panelists, and all attendees for this important webinar on prevention of autosomal recessive disorder. I would not add too much and hand over the session to the Dr. Aarti Madam.
Thank you. Thank you, Walter Bushnell. A very good evening to all. And we are privileged to have the stalwarts in fetal medicine with us today. Because we as gynecologists, we keep seeing cases of genetic disorders, thalassemia, and other problems which are totally preventable. I would like to welcome the esteemed faculty for today's webinar, Dr. Deepika Deka, the eminent geneticist from AIIMS. Ma'am has just finished her term at AIIMS and now she's into practice, and she's the president of Delhi Forum at Dwarka. I would like to welcome all our FOXY committee members and our FOXY Vice President, Dr. Archana Verma, Dr. Mandakini, Dr. Girish Mane, and Dr. Girija Wag is with us. And we'll quickly start the session. And first of all, I'll start sharing the slides. And I would like to welcome our chief guest because Dr. Deepika and myself, for about a month ago, we had decided to do a webinar for our society. And today, finally, we could, yeah, I'll share my screen. So just 1 second. Is it visible now?
Yes, but you can make it full screen.
Yeah, I'll just make it, ma'am. Okay. So, Dr. Deka, ma'am is former chief and professor of maternal and fetal medicine division at AIIMS, and she has now taken over as President DGF Dwarka. She was the former director at AIIMS Kalyani, and ma'am has been actively involved in doing all the workshops for fetal medical science and for the awareness of fetal medicine and perinatology. Ma'am has been past president and former vice president of...
I think we make it short, Aarti.
Yeah.
We have a long program. People can just read the slide.
Yeah. Okay. Welcome, ma'am. I would like to invite you to say a few words about raising awareness about the diagnosis of perinatal disorders to reduce the morbidity in this field.
Thank you, Dr. Aarti Luthra, for inviting me here. I also welcome all the faculty and the delegates who have joined in for this very important topic, which I'm trying to, concentrate on now that I have more time in my hands after my retirement from AIIMS. So basically autosomal recessive disorders, of which we know of thalassemia, sickle cell anemia, they are a real burden to the family members. And not only the cost is there, but it is a mental and a social burden, not just to the family, but to the whole country as a whole, you know. So these are preventable disorders. For example, thalassemia. When we were undergraduates, we were taught of thalassemia as Mediterranean anemia. Those who were studying in these 80s, they would know that. But then now they have control. All these countries, no, Sardinia, and Cyprus, they have been able to control thalassemia. And now it seems that so many more cases are coming up in India that one day maybe they will call it Indian anemia, you know. So we really need to focus on these conditions which are considered rare by the general public, but with the number of our population. So even these rare genetic disorders become millions of them. So our country has to deal with the burden of this genetic disorders, which we know are so preventable. The obstetrician doesn't see a child with thalassemia, doesn't actually see a child with SMA, because a child at birth is quite pink and crying and moving around. It's only after 3 months, 6 months that all these genetic disorders, the symptoms become manifest. So I even once recollect that I had gone for a meeting. I was talking about thalassemia. And then the head of the department comes and tells me, we don't have thalassemia here. So I was quite surprised. And I said, okay, let's talk to the professor of pediatrics. And at dinner time, I talked to the professor of pediatrics and I believe you don't have thalassemia. I was being a little sarcastic. Then they said, no, we have a thalassemia ward just below the gynae maternity ward. You see, so staying in the same big hospital, so you don't realize that the thalassemia could be so prevalent. So now we need to increase our awareness. We are doing HIV testing, we are doing so many other testings, but we are not testing for thalassemia. At least RH, people have started doing it. They're giving prophylaxis, and we hope to be seeing lesser cases of RH isomerization. But thalassemia, we are still seeing a lot. Other autosomal disorders. And so when Dr. Aarti suggested the topic, I just grabbed at the chance of talking about thalassemia and talking about the prevention of these so-called rare autosomal recessive disorders. So the aim of this CM is not to make people geneticists, but they should know, at least the obstetrician should be aware of what the conditions are, because they are preventable, and then only they can, to be the ones who are responsible for the prevention of these disorders. So I thank you, Aarti, for organizing CME. Thank you, the faculty, for coming in, and looking forward to a very active discussion. Namaste. Unmute yourself, Aarti.
Yeah. Our guest of honor, Dr. Archana Verma. Ma'am is, evergreen, ever enthusiastic, and she always supports academics. Dr. Archana is passionate about creating awareness on women's health. I would like to invite Dr. Archana Verma to bless us for this webinar.
Thank you, Aarti. Thank you so much. And I'm really thankful to Dehradun Obs and Gynae Society for such a respectful and such a timely and such an important invitation. It's really my proud privilege to be invited here when the chief guest is none other than my favorite, Dr. Deepika Deka, and then another co-guest of honor, my all-time friend, Dr. Mandakini Pradhan. I used to call her Pradhan Mantri M, like, because when she was fighting elections. And then my all-time favorite, Dr. Girija Vog and Girish Mane and Pooja Loda. There so many people are today here, and to see them for awareness, really this awareness for thalassemia, I really did when I was this public awareness committee chairperson. I did many awareness program, and how the counseling helps, and how this is this awareness helps, because unless and until it is in our mind, we are not going to look for it. So this is very, very important. And when Dr. Deepika Deka is there, so all doubts will be clear, and my best wishes to you all. And because there's a very less time, so I think namaste, thank you, and my best wishes to all.
Thank you. It's my privilege to invite very humble Dr. Mandakini. She's the chairperson for Genetics and Fetal Medicine Committee FOXY. Ma'am is HOD at SGPGI Lucknow, but down to earth and hardcore academician. Ma'am, we need your words of guidance. Dr. Mandakini, please.
Thank you, Dr. Aarti, for those wordings. Dear friends and the delegates, all the faculties, and specifically respected Dr. Deka. When Dr. Deka is around, everybody feels at ease. And this is this is very nice that she has thought of addressing this autosomal recessive disorder, because as she rightly said, that we are not here to make obstetrician a geneticist, but at least to be aware of it. And we must, all of us must remember that a thalassemia major child is born by an obstetrician. And it is we who are responsible for bringing this child, and we can prevent it. It is in our hand. It's only that we should put our acts together, and Dr. J.S. Arora is there to address that issue. And it is very, very heart-touching. Exactly, I have the same experience that Dr. Deepika Deka shared. One of the students from JIPMER said, we have not seen any thalassemia major, because obstetrician will not see a thalassemia major. It will go definitely to a neonatologist or a pediatrician and gets admitted in there. So I asked, how many patients who are on regular transfusion are born in JIPMER, so that you can know what is your disease burden in your country and in your hospital, and you have missed it. And apart from thalassemia, she will be addressing that is the most common disorder. Then we have got a gamut of disorder, that is autosomal recessive, specifically where there is consanguineous family. So we have got excellent faculty. I wish them all the best. The delegates will be learning with this, and such kind of the webinar will help them to clear their doubts, have some new concept to be practiced in ANC clinic. Your antenatal clinic practice will be different. So I wish everyone a great success and happy learning. Thank you, Dr.
Thank you. Thank you, ma'am. Although just one comment, I was wondering, because in private practice, even we get to see, now we are getting HPLC done regularly, but I have some patients whose first baby required transfusion, and then they came back before planning the second baby. Ki, ma'am, in the first baby, after 6 months, the baby was not thriving and he was diagnosed with thalassemia. So ma'am, we want to get all the investigations done. I'm quite surprised that bigger institutes, how can they miss? Because most of the times the obstetricians would get the lady for the second time also, and they become your patient for the whole of their obstetric career. So a lot of other doctors must be seeing these cases in their OPD. It's my proud privilege to, we'll be starting first session, and it's my proud privilege to welcome the chairpersons for first session, Dr. Girish Mani. He's chairperson for Adolescent Health Committee. Thank you so much, sir, for accepting our invite. And sir has been past chairperson of Adolescent Gynec Committee at EMOGS 2018 and 20. He has been awarded best chairperson EMOGS 2018 and 20. Our second chairperson for this session is very enthusiastic, bubbly, and always ready to participate in academics, Professor Girija Wagh. Dr. Girija, a very close friend, she's professor at BVP, and right now she was mentioning that she's working for more than 12 hours a day. Wonderful. And she's a senior consultant at Cloud9 and Apollo Hospitals, Pune. I would request our chairpersons to start the session. by introducing our first speaker, none other than Dr. J.S. Arora. Dr. Girish, please.
Yes, ma'am. At the outset, I would like to thank I would like to extend my sincere thanks and gratitude to Dr. Aarti Madam for this very superb webinar. And really, this is very important point to be propagated amongst all the obstetricians, that we are not coming across the thalassemia cases, but we are producing the patients of thalassemia. At least we can prevent many cases. And according to, I think, 2013, there were 280 million people affected worldwide. And out of this, almost 440,000, they were having the severe disease. And almost 50% of the thalassemia patients all over the world, they are from the Southeast Asian region, especially from India, Thailand, Indonesia, like all this. And almost 12 to 15,000 infants yearly, they are having severe disorder in India. And that's why the screening of thalassemia, especially in the countries like India or this Indonesia, Thailand, everywhere, it should be mandatory. I would say not only essential, it should be mandatory, because prevention of this kind of diseases is the bestest option, I think. And always prevention is better than cure, because prevention is always easy, it is cheaper in all the senses, because the patient, they are suffering throughout the life. So just a small mistake or a small, this thing just done by the obstetrician can be paid by that patient throughout the life. So we are lucky enough to have Dr. J.S. Arora with us, who is thalassemiologist. He is MSc in hemoglobinopathy from the University of London. He is General Secretary, National Thalassemia Welfare Society, the Federation of Indian Thalassemia. He is member of many committees, many societies. He have authored many books also.
Can we hear Doctor?
Am I audible?
Yeah, now you're audible.
Yeah. So I was saying that there are many credentials with Sir Dr. J.S. Arora. I won't go in detail of these lines, because sir की बात से ही हमें पता चलेगा कि आदमी का कद कितना ऊंचा है. So we are eagerly waiting to listen to you, Arora sir. Please, the stage is yours, please.
Unmute yourself, Dr. Arora.
I'm extremely sorry, Girija madam. You can say if you want to say something, please, Girija madam.
I think I'll say at the end, let Dr. Arora come up first, because we should.
Sure, ma'am.
We want
Sure.
Dr. Girija's opinion.
Yeah.
Sure, ma'am. Yeah.
Okay, at the outset, I like to thank Dehradun Obs and Gynae Society, and my special thanks to Dr. Deepika Dekka, who introduced me to the society. And I think I'm working with her for over 30 years, and she has been very helpful to our thalassemia patients, and she had diagnosed many thalassemia, fetal diagnosis of the thalassemia carrier couple. So coming to this topic, my thalassemia, I'll start with some real stories which I faced in my lifetime. See, there is in 1995, there is a family with a thalassemia major child. It's not moving. After some, yes.
Double click on the screen, then it will definitely work.
Okay. After some time, the boy's maternal aunt, that is Masi, got pregnant. She informed her gynec that she had a nephew who is thalassemia major. Gynec said, "You are quite healthy and there is no need of thalassemia test." The lady's real sister, that is mother of thalassemia major, intervened and forced the gynec to get the test done, telling her, "We don't want another thalassemia major in our family." The gynec takes sample and asked the lady to come after 1 week. After 1 week, the gynec told that reports are normal. The lady delivers a male child diagnosed thalassemia major at 3 months of age. The new thalassemia major not welcome in the family and was not transfused. Child succumbed to the disease within 1 year. So what message we got from this is that strong family history of thalassemia and not screening for thalassemia is a crime. Again, 10 years later, 2005, a 28-year-old gentleman approaches me to inquire about thalassemia. He was diagnosed as thalassemia carrier in a screening camp organized by our society. Just a few days back in an MNC he was working. The wife was already 4 months pregnant. She also turned out to be thalassemia trait, referred to AIMS for prenatal diagnosis. The fetus turned out to be thalassemia major. By the time the termination could be planned, lady had crossed 20 weeks gestation. Somehow she got the termination done at this stage, taking risk to her life. The irony of the story is that the husband has seen our advertisement in newspaper on International Thalassemia Day, that is just around 2 weeks back, and asked her gynec to test her thalassemia status. But the gynec had refused her on the ground that there is no history of thalassemia in their family. The message is clear that family history of thalassemia is not a prerequisite for screening for thalassemia. 10 years again later, as story told me, a young lady becomes pregnant in October 2012. She visits to gynec G1 immediately after missing period. G1 advises hemoglobin, urine, HIV, ultrasound, etc. She did not have facilities for delivery. During 3rd month, that is first trimester, I like to emphasize the first trimester, she visits gynec 2, G2, attached to a nursing home. G2 advises some more routine investigations. At 8 months of pregnancy, because of low hemoglobin, the lady was advised HB, HPLC. The lady turned out to be thalassemia trait. Since it was advanced stage of pregnancy, no step could be taken. The lady delivers a beautiful girl in June 2013, and June 14, the girl diagnosed as thalassemia major. So messages: don't miss to screen thalassemia during first trimester. It must be tested during first trimester. So what is the genetic of the thalassemia? An adult hemoglobin molecule has 2 alpha and beta chains. In thalassemia, the synthesis of either alpha chains or beta chains is reduced. If beta chains, in beta thalassemia, there is defective synthesis of beta chain and manifestations are excessive alpha chains and they precipitate. While in alpha thalassemia, alpha chains are reduced and excess of beta chains cause reduced survival. Alpha thalassemia is of 2 types, alpha plus and alpha zero. Alpha plus is mild and its inheritance is not of much clinical significance. Alpha zero is fierce variety. In India, alpha plus is common. In our country, since beta thalassemia is very common, hence the term thalassemia denotes beta thalassemia. So there is thalassemia syndrome. Thalassemia and hemoglobinopathies have a global problem. Alpha thalassemia, beta thalassemia, sickle cell, HB, they all behave like this. HPC, D, Q, they all behave almost similarly. So what happens in thalassemia? See, as you, Dr. Deepika told and others told, child is absolutely normal, hale and hearty at the time of birth. By 3 months to 2 years, the child starts showing symptoms of severe anemia. Treatment includes repeated blood transfusion, investigations, hospital visits, every 2 to 4 weeks, daily medicines throughout life. Cost of therapy is rupees 50,000 to 2 lakh per year. There is always a fear of transfusion, transmitted infections like hepatitis B, C, and HIV. There's loss of time, energy, money, endocrine complications, liver, heart failure, and always having the fear of early death. Permanent cure stem cell transplantation not achievable in all due to non-availability of matched donor, high cost and high risk involved. This is a story of a thalassemia girl. She's 30 years old. She had already received 840 bottles of blood, around 16,800 injections of Disferal. This injection is not given like any tetanus, pre-complex exercise. This is given around 12 hours a day, every night. She had been, for 72,000 hours of her life, she had needle in her body. You just imagine. And she had already spent 33,60,000 only for death spot, not other things. And if we expect her to cross 60 years, she will receive another 1,000 bottles of blood, 20,000 injections, that means 1.2 lakh hours needed in her body, and 40 lakh rupees only for death spot therapy. Since her father had the CGHS facility, so she could afford it. Otherwise, no even upper middle class can afford this much of treatment and trauma. So the prevention is the ultimate cure. Thalassemia is not a disease of few people. 50 million, that is 5 crore Indians have thalassemia. And a person like Amitabh Bachchan, who is around 78 years or so, if a person is so active in life and highly educated, having all resources, if he can be thalassemia carrier, why can't anybody else can be thalassemia carrier? What is the incidence of thalassemia? It is a 1 to 17% different communities in India with a mean of 3.9%. 10,000 to 12,000 new thalassemia major are born every year in our country. Sickle cell disease is more common in tribal areas. It is as high as up to 40% in some areas. HBE is another form of thalassemia. It is most common in West Bengal and North states. Alpha thalassemia is not significant in the Indian context. As per ICMR, 1 out of every 18 Delhiite is a thalassemia carrier. So it is not a few people. And around 200 thalassemia major are born every year in Delhi. 1 thalassemia major is born every 45 minutes. By the time you finish your webinar, there will be 2 thalassemia major born in our country. So why there is a need of prevention? Because it's a lifelong repeated blood transfusion survival, lifelong frequent hospital visits, lifelong costly treatment, and limitation of permanent cure. Around 1,875 crore per year are required to treat around 1.5 lakh thalassemics, and around 40% of voluntary blood is used for thalassemics. And ignorance is very high in public and medical professions. So if we go for prevention, it will reduce the burden of patients, families, and governments everywhere. Once a thalassemia major is diagnosed, I'm sorry to say this, that family starts cursing obstetrician for not advising thalassemia tests. They say, we have been advised all tests. The moment I enter a thalassemia, until the clinic, I say, go for this test, that test, all tests, around say 6 to 10 ultrasound, so many blood tests, but they never advise of HB, HPLC or HB electrophoresis. And again, as Dr. Deepika said, see, HIV is advised to each and every pregnant woman. HIV incidence in India is just 0.25%. HIV means 1 in 400. And thalassemia is 4 out of 100. Is not advised by obstetricians, while a disease which is quite rare comparative to thalassemia is advised to each and every pregnant woman on very first visit. This you all know how thalassemia is passed from parents to children. If both husband and wife are thalassemia carrier, then in each pregnancy, there is 25% chance of having a parents and carrier like parents. If one of them is carrier, other is not, then child will never be a carrier, never be a major, may be a carrier. 50% carrier, 50% normal. So in each pregnancy, there is 25% chance of having a thalassemia major child. Cyprus, Sardinia, Greece, and Italy and Thailand, they have reduced the thalassemia by over 100% in 10 years in Cyprus, and by 90% in 10 years at Italy and Greece. And the theory behind was the most successful control program are based on carrier detection, counseling, and fetal diagnosis. It is very easy to suspect thalassemia. Very, very easy. For any disease, any complication, any patient going to any doctor, he or she is advised CBC. If you see CBC, just look at MCV and MCH. If MCV is less than 80 and MCH less than 27, it may be either iron deficiency anemia or thalassemia trait. And if RBC count is high in comparison to hemoglobin level, the most probable cause is thalassemia trait. Because in iron deficiency, even RBC count will also be low. MCV, MCH will low, RBC count will also be low. But in thalassemia trait, MCV, MCH low, and RBC count will be comparatively high to hemoglobin level. For example, if hemoglobin is 9, the RBC is 3 million, that's okay. It can be iron deficiency. If hemoglobin is 10 and RBC is 6, then it cannot be thalassemia. It cannot be iron deficiency. It has to be thalassemia trait. So by looking at just simple parameters, you can easily suspect thalassemia carrier status. And for final diagnosis, you have to HbA2 estimation, HB electrophoresis, or HPLC. If HbA2 is more than 3.5%, the person is thalassemia carrier. And thalassemia test needs to be done just once in lifetime. So you can get it done even to a girl when she first time comes for during adolescence or during menarche or any time before pregnancy. You can ask for thalassemia test. You don't have to wait till she gets pregnant. If you finally see the HbA2 level, if it is less than 3.51%, it is normal or maybe alpha thalassemia trait. Between 3.5 to 3.9, it is beta thalassemia trait with iron deficiency or interaction of alpha thalassemia, beta thalassemia. So if there is HbA2 less than 3.5, say 3.2, 3 or 4, don't say it cannot be thalassemia carrier. Always ask for genetic mutation. It may be in silent or mild mutation. 3.9 to 9% beta thalassemia trait and more than 9% is HbE syndrome. So what are the fallacies while testing HbA2? If there is concomitant iron deficiency, it lowers HbA2. If you see severe anemia and HbA2 is low, you can first advise, but not in pregnancy. Otherwise, first advise iron therapy for 1 or 2 months, then go for HbA2. But if it is she is already pregnant, then directly go for genetic mutation. Silent beta thalassemia may not have elevated HbA2. Again, you may have to go for this mutation analysis by gene sequencing. Same way, coexistent alpha thalassemia may have normal levels and delta beta thalassemia may have normal or low levels of HbA2. If partner is a thalassemia carrier and there is slightest doubt, ask for a mutation analysis by the gene spacing. If partner is normal, still you can forget of these values. If partner is carrier, always ask for a gene sequencing. Here again, you see, even if a person having hemoglobin level 11.5 to 15 in males and 9 to 14, means up to 14 gram in female may be a carrier. Even up to 15 gram in a male can be a carrier. I have seen many obstetricians advising, because they come to us after the child is diagnosed with thalassemia major. They said, I was told, since your hemoglobin is 11, it is quite normal for a lady. You cannot be a carrier. So never diagnose thalassemia carrier status on basis of just hemoglobin level. I'll give you 2 examples. Your left side see, it is hemoglobin 11.5 and this MCV is 88, MCA 28.5 and HbA2 is 2.3. At 11.5, because MCV, MCH are high, you don't suspect thalassemia and HbA2 is 2.3. So the person is not a thalassemia carrier. In other case, hemoglobin is 14.2. And what you see, MCV 61, MCH 20, and A2 is 5.3. And that person is a thalassemia carrier. So you must, while counseling, you have to tell your patient that carrier state has no disadvantage. The risk arises only when both parents are thalassemia carriers, and homozygous state is very severe and eventually fatal with limited curative possibility, and fetal diagnosis is available and safe. So by this time, you must have understood who holds the prevention key, and that is obstetrician. So always advise thalassemia carrier status during first pregnancy. The time when the lady is most receptive to honor your advice. This is the only branch in medicine where patient is ready to accept 100% whatever is been told, to pay anything with happy. People may pay for cardiac surgery, other surgery, the medicine. But when a lady comes to obstetrician, she is the most happiest person to pay for the to obstetrician or his advice. So this is the right time you can advise HbA2 status. So first of all, screen. Just a minute. Yes. First of all, the screen the pregnant on first visit. If the screen test is positive, confirmed by HbA2, HbLC of husband. If husband is not a trait, no further action required. If husband found a beta thalassemia trait, it needs prenatal diagnosis. If the fetal is thalassemia major, pregnancy can be terminated as per the family choice. And if it is carrier or normal, they can continue the pregnancy. So one partner should be tested. If one is beta thalassemia trait or delta beta trait or sickle trait or E trait or D trait, heterozygous or D homozygous or HP thalassemia, then partner must be tested for thalassemia syndrome. And when prenatal diagnosis advised, if both are thalassemia trait, one is trait, other is HBE trait or homozygous, one is trait, other is sickle trait, both are sickle trait, one is sickle trait, other is HBD trait or homozygous, one is delta beta, another is beta thalassemia, and one is beta delta and beta, and other is beta thalassemia. In all these conditions, you need to go for prenatal diagnosis. And when it is not required, when both partners are HBD trait or homozygous, both partners are HBE trait or homozygous, or one partner is HBQ India and other is beta thalassemia trait. So this is your domain for pre-diagnosis, coronary venous sampling, amniocentesis, and photosynthesis. And now you have pre-gestational diagnosis as well. The cost at various centers in Delhi, at Loknaik, it is no cost, zero cost. At AIMS Delhi and SGPJ Lucknow, PGH Chandigarh, around 2,000 to 4,000. While at private setup, it was around 20,000, 40,000 different setup. And PGD, maybe 3 to 5 lakh, that you people know much better. So these are few thalassemia major patients. We seek your help, support. I request to you that these children should not go to this much volume. We don't want that group should have grown to this much bigger group. So you must remember that thalassemia test HbA2, HbLC needs to be done just once in a lifetime, then do it right now. So there is an old saying that inferior doctor treat full-blown cases, mediocre doctor treat to prevent complications, and superior doctors treat to prevent disease. You all sitting over here are superior doctors. I seek your help to control thalassemia because it is a teamwork. It is all primarily by the obstetricians, by NGOs like us, and parents to counseling their families, government, everybody is involved. It is a teamwork. Only then we control thalassemia as it has been controlled in some other countries. Thank you very much.
Thank you very much, Arora sir. It was really an eye-opener for us. And this is my request, madam, we should keep sir's talk in Foxy main major conference, because really this knowledge, or at least this much of, I mean, the problems these guys they are facing in their whole life, not the guys, but the whole families, they are suffering literally. It should be spread amongst all the obstetrician. Over to you, Girija, madam, please.
Thank you, Dr. J.S. Arora, for throwing such a wonderful light, and we can see your intense emotions behind this. We have a similar person in the city of Pune, one of our hematologists, Dr. Apte, who is extremely intense about this. And probably that made us do these tests universally in all our patients at this point in time. And I feel that we have to wake up to this particular understanding that when we are asking women to do their blood groups, at the same time, we must also ask them to do an HPLC and maybe put it in a laminated form, so that whatever time she goes to the doctor, it's always there, so she doesn't have to repeat it again and again. There's a lot of dearth in awareness amongst the population. That's also terrible. And so many times I put it in the chat box that many times I am criticized for the amount of screening that I do during my antenatal care, but I don't care because I feel it's going to help us, prevent a lot of malady. So you threw a wonderful light on this. And sir, I must share with you one thing. Some time back, about 7 to 8 years back, I went with the NRHM director to our places in Maharashtra where we have sickle cell disease in very, very large numbers, and that's in the Nandurbar district, where women die and many children are born. And what they did there with the help of the government and the WHO was they had a tagging system. So they had these card tags which were given to people in the field, and they were advised that this tag with that tag should not get married. So there was a huge program that was being undertaken, and then they were able to control the sickle cell disease in a large quantity. So there are efforts going on. What we as obstetricians can do, and which we should never forget, according to me, and the message that we get from you, sir, is that we have to wake up to this particular disease. And another thing I must say, this is not something that I can say to Dr. J.S. Arora, but I want to say to my colleagues, please screen women every time, even for hemoglobin. Simple complete blood count doesn't cost so much. So simple complete blood count, blood group, and HPLC all together will not cost you more than 1,000 to 1,200 rupees. I think that will save a lot of lives, because we cannot forget the goal that by 2030, we have to achieve the maternal mortality ratio of 2-digit numbers, that is 70. So this is our responsibility, and only 8 to 9 years are remaining. So therefore, thank you, sir, for being here. Thank you, Aarti, for giving this platform for me to express what I wanted to say. Thank you.
I just wanted to one or two messages, please.
Yes,
Because,
yes, sir, please.
Yes.
What we have seen many, because in thalassemia major, we advise that iron is poison for them. They should not take any iron. Even they should avoid iron-rich diet. So taking this clue from this, sometimes obstetricians don't give iron to pregnant thalassemia carrier people. So this message should also go from your platform that pregnant thalassemia carrier lady should be given as much as iron as you give to a non-thalassemia carrier. So thalassemia carrier can be given iron if there is any iron deficiency. And another thing I like to say, and since some of the Dr. Deepika and some other ones saying we are not seeing thalassemia major children. So though I showed that this bad picture, but there is good news as well. Now we have many thalassemia major patients who are getting married and having children. Now you will be seeing thalassemia major girls coming to you for planning a pregnancy or after pregnancy. So be prepared for them, that you guide them rightly, so they have a normal pregnancy and they should also enjoy the happy family. Thank you.
Thank you, sir. Thank you very much, J.S. Arora, sir. And thanks a lot, Aarti madam and Dekha madam. Really, thank you very much. And one more thing, I want to wish very best luck to Dr. Girija madam, who is going for the post of vice president this year. And I expect everybody's support with my sister, Dr. Girija Wagh. Best wishes, ma'am.
Thank you so much. Thanks.
Best of luck, Dr. Girija. And big thanks to Dr. Deepika, ma'am, for suggesting to invite Dr. Arora. Dr. Arora, you have really, brightened up everyone's brain, and your messages are very clear and crisp to all. Thank you so much. So, ma'am, I would like you to comment on Dr. Arora's talk, Dr. Dekha ma'am and Dr. Mandakini ma'am, then we can move forward.
Yeah, I have been, as I said, working with Dr. Arora since the 80s, and I have seen his passion. So, if you interact with thalassemia patients, their families, we have been working with the thalassemia patient doctor, meetings. And these young boys, so active teenagers, they come up and they say, Auntie, I do exercise like Salman Khan, but why I can't have muscle like him? And then one boy once also told me that, why didn't the obstetrician tell my mother that the baby, me, I am a thalassemic? They have their rights, and they probably sometimes they must be having a lot of psychological problems, Dr. Arora, because they feel that they could have been much better, and they feel depressed, and it is therefore a lot of things are going along, not only blood transfusion, but a lot of psychological trauma.
Yes.
Psychological trauma, not only to them, but to the family also. So
Yeah.
it's very, very important that Foxy and all the local societies should raise awareness, knowing the figures. So I told Dr. Arora today also, I think, that please tell us the amount of burden of the disease on the family, on the society, on the child or the person with thalassemia. Just the other day, Dr. Arora sent me a patient with thalassemia who wanted to become pregnant. And she is now 31 years old, and her obstetrician told her, her local doctor told her, you cannot become pregnant.
They can.
So you see, they also want to have a normal life. So we should do our best to see how they can achieve the goals of a normal family life. We can treat them. We can look after them. We should guide them intelligently.
Yeah.
Thank you.
Thank you. Thank you, ma'am. Dr. Mandakini, ma'am.
Yeah, that is very nice of Dr. Arora, highlighting and showing that how passionate he is about. And anyone who has come across all these children and now they are married and wants to plan a pregnancy. The same patient is like Dr. Deepika has sent to me. Now we are.
He lives in Lucknow.
Yeah, the patient is in Lucknow. So this again, we will be seeing our own fruit that we did some 30 years back when this screening was not available. Dr. Girija rightly said screening is widely available. Please stop screening for aneuploidy, but then please start screening for thalassemia. It costs nothing, less than 500 rupees. So I hope that Government of India takes this up. This is there in the parliament, like on the table, that all women should be screened as like any other blood group, and this hemoglobin that is recommended by Ministry of Health and Family Welfare. There is a recommendation for screening by hemoglobin HPLC, and hope it comes up as early as possible. Dr. Arora, thank you so much for showing your passion and at least sensitize.
Thank
you.
So Foxy, Mandakini, you also there, Verma. I think Foxy should make it, that mandatory screening. The way we do blood group.
Yeah, we have
hemoglobin.
Last year there was a recommendation of pre-conception counseling recommendation, and there in the clinic this thalassemia should be screened. We have recommended, but as you know that like it goes on like this. Why government hospital are not following is because this is a paid test. Now they say that in a patient who comes to a government hospital cannot do any paid test. So there are some technicalities into it. If government recommends this test, like TSH is now a recommendation. So if Ministry of Health and Family Welfare recommends it to be done during pregnancy, then it will be recommended as hemoglobin and blood group. So that Foxy has already taken it up.
Thank you, sir. And thalasssemic girls getting married and having babies, it just shows the quality of care our country is providing with blood transfusions and iron chelation, that they are able to reach adulthood. I really appreciate your efforts, sir. Thank you so much. And everyone is really glad to get your opinion on that. Thanks. We'll move to our second session now, and we are going to invite our very dear Dr. Vandana to be talking on the fetus are genomic joint in the womb. Radhika, please invite the chairpersons for session 2.
Good evening, everyone. It is a pleasure to be here with all the seniors here. I'd like to invite the chairpersons for the second talk. The first chairperson being Sujata Bhatt, ma'am. She's a senior consultant at Kailash Hospital, Noida, and her areas of expertise are in high-risk pregnancies, menopause-related problems. She's also been the president for the Noida Obs and Gynae Society, the organizing team for the North Zone Yuva Foxy in 2019, and ma'am has many credits to her name. We welcome you, Sujata, ma'am. I'd also like to invite dear Ruchira Nautiyal, ma'am. Ma'am is the professor and head at Jolly Grant Himalayan Institute, has more than 18 years of teaching experience, many publications and awards to her name, and her special interest is in high-risk OBS and gynae endoscopy and maternal fetal medicine. We'd like to invite you, ma'am. And we'd like to invite Dr. Vandana Chadda, ma'am. Dr. Vandana Chadda, ma'am, is...
Dr. Sujata will be introducing Dr. Vanna. Yeah.
Sujata, ma'am, please introduce Vandana Chadda, ma'am.
Yeah, Dr. Vandana, I mean, is so well known to me, and I'm sure she's known to several others already over here. But still, I will do the formalities of introducing her. Everyone knows she's a fetal medicine specialist practicing in Greater Kailash, having her own center. Her areas of interest, fetal imaging, and everything to do with fetal medicine, fetal interventions, fetal therapy, multiple pregnancies, fetal genetics, and fetal autopsy. And she has several awards, publications, and her major achievements, 23 years of experience in prenatal diagnosis, interventions, and fetal genetics. Set up the fetal medicine unit in Moolchand in 2005. Actually, I've known her since then. Membership, she is the Fetal and Genetic Medicine Committee member of FOGSI from 2006 till date, and she is the AOGD executive member of SOFM2. Dr. Vandana, we are just eager to listen to you because I know you'll make us wiser at the end of your talk.
Thank you so much for your kind introduction. And I'm so happy to be sharing this evening with all of you. Can everybody see my slides?
Yes, we can.
Okay. And I'm audible.
Yes, 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 yes.
Okay. Because what we thought was we'll keep our topic as our genomic jaunt in the womb, and where we started and where we've come, and kind of a journey which we've had in the womb for the fetus as we've gone along. So we know that this is like several years back, maybe 20 plus years back, when we could only look at chromosomes. And this is one of my earliest Down syndrome that we've diagnosed. You can see the image there. The baby has a large nuchal, a large bladder, and there was this extra chromosome the baby had, the trisomy 21. I think it's so this is where we started. The chromosomes are like books. And the reason I start with this concept is I want to travel from the chromosome to the gene, because unless we understand that concept, we won't understand what is autosomal recessive disorders. So broadly looking at 46 books that we have in our body, in each nucleus of every cell of our body, which code for all the functions of our body. And those are the 46 chromosomes, or the 46 books that we have. An extra book, a whole book which is extra, is an aneuploidy, which is what we see here as a trisomy 21. I'm having problem changing my slide. So is it something to do with... So this is another kind of clinical scenario that we see. You have a fetus which has an obvious cleft. You have that extra finger there. And when we see the fetal karyotype, we see that the baby has extra stuff here. So we have 2 copies of the 13th chromosome, 1 copy of the 14th here, but here you have a 13 attached to a 14. So this is an unbalanced translocation that this fetus has, and therefore fetus is abnormal, having trisomy 13 like features, because the mother had a balanced translocation and the baby got this aberrant chromosome from the mother, hereby causing a extra trisomy like features. So this can happen, and again this is at the level of the chromosomes and not at the level of the gene, because the mother is having what we call a reciprocal translocation. However, as we moved on further, and in the early part of this century, we noticed that a lot of children who had intellectual disability, we could test them and get extra information using a test called the chromosomal microarray. And this diagnostic yield was maybe 12 to 15% over the conventional karyotyping. And gradually, towards 2012 or 13, we did start using prenatal microarray in our specimens as well. And it was clinically useful because it gave us more yield, maybe 6% more information in various clinical scenarios. Even if there is no abnormal phenotype, maybe 1.7% of fetuses could give us some extra information, a deletion or a duplication using a microarray in the prenatal setting. But this, again, we haven't really reached the gene level. If you're again looking at what the concept is, if you're zooming on in this Google map, you zoom on to India, you zoom on to further zoom on to the state of Uttar Pradesh, say, or you zoom on further, you will get more and more information on the same thing. And eventually you're looking at the Taj Mahal, and you can even look at the Gumbaj of the Taj Mahal to see if something is missing or something is different there. It's the same thing in a chromosome. You're looking at the same chromosome more zoomed up, and you get more information using a cytogenomic surveillance like the microarray, where even if there are 50,000 base pairs missing, perhaps if you use a good quality microarray, you can pick up that particular deletion in a prenatal sample as well. So what do abnormal microarray results mean? That you could have a pathogenic, a normal, or a variant of unknown significance. But we haven't really reached our level of autosomal recessive gene type. Here we are still looking at broad deletions and duplications. As you've seen this particular case, a baby with a large nuchal and abnormal micrognathia and various CNS findings, hard palate defect, imperforate anus. In the next pregnancy, again, the baby had a tricuspid atresia in early pregnancy. And eventually we diagnosed the baby in a microarray by having a large deletion duplication, which would not have been picked up by a conventional karyotype. And the mother had a balanced translocation. So till now, we haven't covered what is autosomal recessive disorder. We are still broadly looking at the chromosomes. So the books, or if we are missing pages in the book, perhaps that's equivalent to a deletion duplication. But if we start reading each line of the book, each letter of the book, and we look for missing letters, and so the book has multiple chapters or stories or multiple recipes, and because of missing letter, a particular recipe or a particular story gets disturbed. That is what is the concept of a Mendelian disorder. So in Mendelian disorder, we will start reading this book, and instead of a cat, if you have A missing, that you will not be able to read that particular word. And so that is what is the concept of a mutation. And various recessive disorders would have missing letters in your story, and that's why you could not interpret the story. So this is a story of the beta globin gene chain. And here the missus or the wife is carrying a different word here, a missing word here, because of which she has a 619 base pair deletion. We've already diagnosed her as a thalassemia minor, but unless we read her story and we find which is the missing word, which is the missing letter here, we will not be able to help our fetus. So this is the report, the gene mutation report of the minor carrier pregnant woman. And her husband's test also needs to be done. And you look at her husband's report. Again, we found the mutation here, which is the FS829 mutation. And then we check our fetus, and we see that the fetus is carrying the mutation both of the mother and the father. And since both the alleles are affected, the fetus is a major. And so we would advise termination for this particular scenario of prenatal testing. In our next case, so that is what is an autosomal recessive disorder, where both parents were carriers. They were not having symptoms other than what we perceived as a thalassemia carrier status in the hemograms. And because we knew the mutations of the parents, we could offer prenatal testing for the fetus. In another case scenario, we have the first pregnancy where a male baby was born who had symptoms of cystic fibrosis. And subsequent pregnancy, in the next pregnancy, this is the test report. So the mother had a heterozygous mutation delta 508, which is the common cystic fibrosis mutation. So again, we have read the cystic fibrosis story for the mother. We found the missing letter in the mother. In the father, again, the common mutation, similar mutation was there. So we've got the missing letter for the father as well. So now we can go in and check the fetus, the CVS, and this particular pregnancy, the baby was homozygous, carrying mutations in both the alleles, and therefore the fetus was affected and was offered termination in this pregnancy. However, in the third pregnancy, if you look again carefully, the mother is heterozygous, the father is heterozygous, the baby is also heterozygous. So the baby had one normal allele and one affected allele. And so the baby is a carrier like its parents and can be carried forward. So this couple eventually had a normal pregnancy. The cystic fibrosis carrier frequency is pretty low in the Indian population, about 1 in 100. So the incidence is low, but it's not uncommon. Perhaps one case in a couple of years is what we would see. And this is the CFTR gene on the 7th chromosome, the story which we were reading for the parents and looking for the missing base pair. So this is the next case where in a previous pregnancy, she's had a male with a bilateral hydrothorax and ascites. And these are the ultrasound findings of the current pregnancy, where again, you can see there is large nuchal edema, there is ascites, and there is bilateral effusion. And the middle cerebral artery peak systolic velocity is normal. So there's no very marked fetal anemia. The baby's hemoglobin on a cord blood sampling is 11, and there's nothing remarkable here. The chromosomes were normal, but when we checked, because of the recurrent hydrops in this clinical scenario, the tests of choice would be enzyme assays for these various tests, which would be common causes of recurrent hydrops presentation in a fetus. And as you can see here, the assay for the beta glucuronidase enzyme, the MPS 7 is low. So this is the diagnosis made for this fetus, and that was the cause of the recurrent non-immune hydrops fetalis in this particular couple. So we can offer PND because we now know the cause, and we can offer early prenatal diagnosis and tell them that the recurrence risk would be 25% and so on. So again, this is an autosomal recessive kind of. So as we are moving forward, we started covering more and more recessive disorders. So I put a couple of cases from last couple of years to highlight the same. This is a previous child with a floppy infant polyhydramnios in the antenatal period, and normally we would not have reached any particular diagnosis, but now with the advent of clinical exome and whole exome, we are looking at various mysterious clinical scenarios and finding answers here. So here you can see after a muscle biopsy, the baby's there was a clinical suspicion of a glycogen storage disorder, and lo and behold, in the exon clinical exome, you can see exon 3, there's a homozygous mutation which is pathogenic. So the diagnosis of glycogen storage disorder type 4 was confirmed. And because of this mutation, which is known, we could go in and do prenatal diagnosis early on in the subsequent pregnancy, and the subsequent baby was normal. This is another clinical scenario of a maple syrup urine disease. Here, 2 successive babies born with MSUD, and the brother and this particular wife are getting married, and they're asking for clinical counseling whether their child will be affected. This is again another kind of clinical scenario. So if this particular person has had MSUD, this person is a carrier. So it is possible that his brother is also a carrier. However, if this lady is not from the same family, it is not a consanguineous marriage, the possibility that it's a MSUD will be born here and autosomal recessive condition will be passed on here becomes low. I think I have few more, just a couple of more slides. So we can counsel that they can be rest assured, or they can screen the brother and the wife for carrier status for maple syrup urine disease. In another case scenario, this is an anophthalmia with delayed motor milestones. And we went in and did a clinical exome, and we found the answer in a SOX2 gene. This is autosomal dominant condition. However, the parents were not affected. And so we did fetal diagnosis, but you can see this is an AD condition of de novo variety. And so not really expecting a recurrence here. So this is autosomal dominant scenario. SMA again is common, and we do much more than cystic fibrosis, spinal muscular atrophy. We do see cases in India, and we can offer PND if we know if you do the mutation testing again in the fetus. A clinical scenario here of arthrogryposis recurrence 2 to 3 times, where we found the answer in clinical exome, a pathogenic mutation, autosomal recessive. And again, if we find the mutation, we can offer prenatal diagnosis in the subsequent pregnancy. This is a case from Dehradun only. This is a child who is deafness and retinitis pigmentosa, and we found a pathogenic mutation in the MYO7A, making suspicion of diagnosis of non-syndromic deafness type Usher syndrome type 1B. And with the mutation known, we can offer the PND for the subsequent pregnancy. So we are covering deafness, floppy infants, and so many other clinical scenarios which normally we would just ignore and not really have answers to. Oculocutaneous albinism again is a recessive condition which we see quite often in North India, where if we find the mutation fairly easily, and we can offer PND for the subsequent pregnancy, as you can see in this particular case scenario. So I've just highlighted some of the names. You need not really go into details, but if you know the common recessive conditions which are prevalent in the country, and you choose to investigate the parents, find the mutation, find the missing link there in the story, in the parents, only then, because the common statement is कि हमें वो पुराने बच्चे को तो चेक नहीं करना, हमें पेरेंट्स को भी चेक नहीं करना, हमारे बस नया बच्चे को चेक कर लीजिए. So you have to give a very crisp message to the parents after delivery that unless you check the parents and the index case properly, investigate the index case properly, prenatal diagnosis for subsequent pregnancies is very challenging. And that's the message I want to give from my talk. Thank you so much for your patience.
Thank you. Dr. Ruchira, a quick comment by you, please. Vanna,
Yeah,
you talk was
thank you, Dr. Vandana. And this was a real sensitizing talk for the routine OB/GYNs practitioners. My only one basic question is, how soon should we refer the patient to you, or maybe a couple who has had such a bad outcome for their baby? Should we take up the initial CMA test for the couple and then we refer them to the specialist, or the straight away while obtaining a history, the patient should be directed to the genetic specialist? As a routine practitioner, this was my basic question in a medical college.
Yeah, so as you can understand that so many of these recessive disorders have such varied clinical presentation, and with such a heterogeneous medical infrastructure that we have in our country, it's not possible to have one glove that fits all kind of answer here. So if it's a thalassaemic baby, we know that at 6 months of age, the baby will get low hemoglobin, and so it's easy to kind of decipher that there's a problem. And I would say when you have properly worked up the child, when you've established its clinical natural cause
diagnosis.
Yeah, the pediatrician is very important here. The pediatric geneticist, we have one in our panel, and the subsequent is very important, their input. So once you've worked up the index case clinically, only then we would start. And the test of choice should be, I think, decided by the specialist who's seeing the, we should not kind of do blanket testing without investigating and without assessing clinically the child properly. So I think.
Yeah.
Thank you.
Thank you, Vanna. Yes, ma'am.
Yeah, Dr. Ruchira, Dr. Vandana is very right. But then with this COVID, what it has taught us is contact your, wherever you are sending the patient, first be in touch with people who are, who can guide you. So do not send the patient, be in touch with these, say, experts. And then accordingly, like so many tests can be done from the local to the lab, and after the patient can be called. So
Yeah, thank you, madam.
communicate and then communicate.
Very true. Thank you so much.
Thank you. A final word by Dr. Decker. Then we'll be moving to much awaited panel by ma'am. Dr. Decker, ma'am. Ma'am, you have to unmute, ma'am. Ma'am, please unmute.
Yeah, so what Dr. Vandana Chadda has done is that she has sensitized the obstetricians present. I can see there are 117 participants about what are the conditions that can be diagnosed in utero. And so unless the obstetrician knows that such a condition exists, and basically the parents would come first to the obstetrician, and the obstetrician, the question raised was when to send. So the moment you find that there is a problem, and if the obstetrician is not confident to give a correct solution, they should immediately refer to the fetal medicine specialist as soon as possible, preferably before the next pregnancy is planned. So obstetricians need to know the basics of genetics. Thank you.
Thank you. Thank you. Radhika, please introduce the chairpersons for the panel.
I'd like to introduce Dr. Rakhi Singh, ma'am. Ma'am is a director and senior gynecologist and IVF specialist. And ma'am is at Avalon Clinical Maternity and Fertility and IVF Center. Ma'am has been a very senior member of the Obs and Gynae team from the Noida Society. Also been the joint secretary of the UP chapter SR, joint secretary for the North Zone Nuva Foxy in 2015, and also held a position in the member of the MTP committee Foxy 2015 to 2017, and the treasurer of the UP state ISPAT. We welcome you, ma'am. I'd like to welcome Dr. Manish Machve, sir. He is a director and consultant at Machve Hospital, Center for High Risk Pregnancy and Advanced Endoscopy, Pune, and a consultant endoscopist and PG teacher at Ruby Hall Clinic, Kamla Nehru Hospital, Pune. We welcome you, sir, please.
Good evening.
Thank you, Radhika. At the outset, Radhika, I am right now, this is a very, very old CV. I don't know from where you picked it up. Right now, I am the endocrine committee chairperson. And apart from that, I am vice president for UP state of SR, the post what I'm holding, not the joint secretary. And I did put up my CV. It's okay. We are here gathered here for the much awaited panel to be discussed by none other than Dr. Deepika Deka. And let's have the CV of Madam, please, to be introduced.
Introduction has already been done.
Yeah.
Okay.
We can go straight to the panel.
Welcome, Dr. Manish.
Welcome, Dr. Deepika, ma'am, because you are the best person over here to deal with all the genetics and all that, ma'am.
Yeah.
Over to you, ma'am.
And we can start the panel. Everyone knows the panelists also. Yes.
Okay, good evening,
but
everybody.
I think it's better that we introduce them.
Can I just steal 10 seconds before Madam has a go? So good evening, everyone. At the outset, let me thank our Foxy president, Dr. Shanta ma'am, Dr. Madhuri ma'am, and everybody from Foxy, and Dr. Aarti. Thank you so much for involving me here. I actually wanted to introduce Deepika ma'am, but since she's already been introduced, I'll tell you what I know about her. India is known by the stalwarts of gynec all over. So for example, if you go to South, it is known by, VP Paili or PC Mahapatra. You go to East, it is known by Dr. Sengupta or Dr. Mukherjee. You come to the West, it is known by probably Dr. Pankaj Desai and Dr. Behla Mankresaria. And if somebody is known from the North, it is Dr. Deepika ma'am. So, we have been scared about her. Yeah, of course, ma'am, you don't know. As a postgraduate, we were very scared about you because all the research papers that used to come on pre-eclampsia on your names, and we had to know them. And if we did not know them, our seniors used to give us left, right, and center. So we had a big time, following you as postgraduates and as lecturers.
Wow.
So that is one thing which I have to tell you. Second thing, a very big thank you for involving me in a clinical setup. I also do a lot of clinical stuff. It's not just medical legal. So thank you very much. But medical legally also, I'll tell you that, what we are discussing and I'm hearing, as a branch, fetal medicine is something which attracts maximum compensation when the cases go to the court. So I'm not trying to scare you. All I'm trying to tell you is because it's such a evolved and specialized branch, we have to be very careful. And I completely agree with Dr. Mandakini that we have to have our protocols in place. Unfortunately, Foxy does not have very clear protocols in fetal medicine. So I request all the experts to, work on this, talk to the ICOG guys, because those are the ones, that is the college which is attached to Foxy. And once we have our own protocols, everybody will follow and they are accepted in court. Next point is, about what we are discussing just now, aneuploidies, autosomal recessive disorders and all. Trust me, there are a lot of obstetricians which do lot of high risk practice, but they have lot of, confusion about these things. So I'm very happy that today we have such good experts who are trying to teach us. So more than a chairperson today, I am here to learn. I'm going to take down notes, and it's going to benefit me in my practice. So that is something which I wanted to tell. And the last thing is, when I saw the panelists, right from the moderator to everybody, all the expert fetal medicine specialists, the only thing which I saw was lovely looking, charming ladies, and the bold and the beautiful and the intelligent, because the bold because they are into fetal medicine, beautiful because everybody can see, beauty lies in the eyes of the beholder, and extremely intelligent because they are the ones who come out with such good guidelines which will help us in practice and also help us prevent any litigation which comes in future. So I think I have overrun my 10 seconds. Sorry very much. And I will not come in between again. Thank you very much. I want to learn. So I am all ears and all eyes now.
Thank you.
Oh, great. Great, Dr. Manish. Nicely put up. Thank you.
Over to Deepika, ma'am. Much awaited.
I must say, we are all ladies overwhelmed by all the response that we are getting. Compliments. Thank you very much, Dr. Manish. Yeah, but I'm not here to scare you today. So let's proceed. I'm going to share my slides now.
Yeah. In the meanwhile, Dr. Sujata has raised her hand. Yeah.
But somebody needs to introduce the panelists. Dr. Aarti Luthra, Vandana Chadda, you have all met. Now, Latika Chawla, she is working as, Latika, are you additional professor now? In
Assistant professor at AIMS Rishikesh, ma'am.
Pooja Lodha.
She's at Pune, fetal genetics specialist.
Yes, and Divya Agarwal, I think she's in Cloud 9.
Yeah.
Yes. Right. So I just want to introduce, the introductions has already been given, that genetic diseases are really now becoming a more important public health concern than malnutrition and dehydration and diarrhea. So we know that father of genetics is Gregor Mendel. And we already talked about the autosomal dominant recessive X-linked Vandana has. What I want to say is obstetricians should know about the common conditions, because most of these diseases can even be fatal. We talked about bone marrow transplants, but these are very costly, and therefore prevention is the need of the hour. So let me start by inviting Dr. Aarti Luthra to tell us, though we already have had a background about what is an autosomal recessive disease versus trait, and how does the fetus inherit it?
Autosomal, thank you, ma'am. Thank you for planning the whole show. As we all have been hearing, autosomal recessive disease means the baby, the person inherits one recessive gene from each parent. The parents are normal looking, but one recessive gene from each parent makes the child suffering from autosomal recessive disease. And trait is when one is just carrier for that disease. So if there are two recessive genes, it becomes autosomal recessive disease. But if one is carrying just one recessive disease, one becomes a carrier. Like you have shown here, if there is an unaffected carrier father and unaffected carrier mother, so there are 25% chances that the baby can show a fully blown disease. And there are 25% chances that the baby can be normal also. And there are 50% chances that the babies will be carrying the disease. So it's very important that if there is one affected child, we have to check both the parents, and we have to investigate the next pregnancy fully to rule out a full-blown disease in the next sibling.
Yeah. So Dr. Vandana Chadda, you already talked about a lot, aneuploidy and everything. So just to recapitulate, what are the commonest autosomal recessive disorders? Obstetricians do not see these children, so they must be quite morbid, and some of them are even fatal. Dr. Vandana Chadda, please.
Thank you, ma'am, for the opportunity. We've discussed a lot, and as everybody must have understood by now, that beta thalassemia is something we really worry about in our country. It's quite prevalent. The prevalence of beta thalassemia, the carriers are as high as 5% in Delhi, as we've just heard. Other than beta thalassemia, there are other thalassemia syndromes like homozygous sickle cell syndromes. Those are the ones, E-beta thalassemia, or if sickle combines with some of the other hemoglobin variants, then those would be worrisome. Cystic fibrosis, as you can see in this, they mentioned here, cystic fibrosis not so common in India. Perhaps 1 in 100 or 1 in 90 would be the prevalence of sickle cell anemia. G6PD, congenital adrenal hyperplasia, again, I think pretty high prevalence is there. Galactosemia, phenylketonuria, all of these would also fall some of the metabolic screenings that we do. So spinal muscular atrophy again is up there in the list. What we see commonly is in ultrasound is also the polycystic, autosomal recessive polycystic kidney disease and things like Meckel-Gruber syndrome, because those variants are prevalent. So commonly, I think in ultrasound practice, we would see those things, and those are rare things to see, MPS, etc. The storage disorders. I've shown a case, I think, of a storage disorder, but that would be very rare to see, which had presented with recurrent eye drops.
Yeah.
Setting.
So autosomal recessive, you need one gene from either parent. So if they are blood related, there's always a higher chance, don't you think so, Dr. Latika? Is that a risk factor? And what are the conditions which are common in the parts of the country? Like I belong to Assam, so I myself have hemoglobin E disease, though my hemoglobin is usually in the range of 13, 14. But when I have a stress, I actually become quite jaundiced. There is hemolysis. So because I belong to Assam and my father was once admitted, and that's when we diagnosed that his jaundice was because of hemolysis, not because of a hepatic factor. So we need to know about what conditions are common in which part of the country. Like North India, I think it's a crime, someone said, if we don't test for thalassemia. But it won't be such a crime if we don't test for hemoglobin E. Whereas in Bengal or Assam, hemoglobin E is more important. So Dr. Latika, please tell us.
Ma'am, consanguinity is a definite risk factor for autosomal recessive conditions. And the risk of inheritance of autosomal recessive disorder increases to about 8% if there's a consanguineous marriage. So in a lot of areas in our country, in some communities, consanguinity is very common. And consanguinity is also very common in Hindus in South India, because it's very commonly they get married to the mamas. So that's almost like a normal thing in the South. If you look at the world map, India, the entire whole of India is actually a part of the thalassemia belt. So that is something that we are very scared about. However, the Punjabi and the Sindhi community, the areas that are bordering Pakistan, they are the ones that are most commonly affected. You will find cases all across the country. As far as Odisha, the middle of India and the South India is concerned, HBS is also very common. Like sickle cell disease is very common there. Interestingly, my HbA2 is 3.4%. So probably I need to get my own mutation testing done. I'll get it done after Aurora sir's lecture today. So these are the things that are very common.
Yeah. So beta thalassemia, is very common. ICMR study has shown that it is a 4%. Sickle cell disease, as Dr. Latika, you said, we had one of our residents whose sister had sickle cell because they belonged to Madhya Pradesh. So all these places, then hemoglobin E, as I was saying, is common here. And spinal muscular atrophy, I just put in the slide, there was no regional thing, but it's pretty common. people don't know, obstetricians don't know much about this condition. So I thought it would be nice to make people aware of all this. The Dr. Pooja Lodha, like, people do get confused. In fact, even some of the very well-read ones get confused about what is a carrier and who is the, what is a disease. And then if one parent is affected and the other parent is a carrier, what is the risk?
Ma'am, I would like to answer because Pooja is still in the other webinar.
I thought so.
Yeah, you were right, ma'am. They got delayed. So if only one parent has the disease and the other parent is normal, there are 50% chances that the offspring can have the disease and 50% chances that the offspring will be completely unaffected. But that 50% will be a carrier state in the offspring only. And if only one parent is a carrier and the other parent is normal, then only 50% of chances that the baby will be a carrier. Otherwise, the baby will be unaffected. So, yeah, there was one more question. I think if both the parents are diseased, yeah. This we have discussed that only 50% chances of baby being affected yeah.
Yeah. So if you look at the diagram that we showed about the way it's inherited, so a thalassemia major patient, as I was saying, the one from Lucknow, Dr. Mandakini, and the obstetrician had told her that all your children will be thalassemia major. The husband is totally normal. He is not even a minor. So there she could easily go and have a child, though of course the risk of the children being carrier is always there. So it's very, very important for all obstetricians present here to note what are the chances if both parents are carriers, if one person is a carrier, one person has a disease, and one person has a disease and the husband is normal, the other person is normal, and diseased person and the other person having a trait. So these are very simple mathematical calculations which can be easily deduced. Dr. Divya Agarwal is here. So what POG? Somebody was asking this question also. When should the obstetrician refer a case, an autosomal recessive disorder, let us stick to that, to the fetal medicine specialist? I once had a very senior professor calling me up from another place that I'm sending a patient and she was almost like 27 weeks pregnant. Please do CVS because both of them are traits. And wanted me to do the CVS the next day because they are in a big hurry. First of all, 27 weeks, what will you do if you... And then secondly, can we actually do the CVS the next day? So obstetricians should know about when to refer. Also they want to know what is the best time for the test, the result, it's going to be what, and then what is the cost. So Divya Agarwal, could you please enlighten on this?
Sure, ma'am. Thank you so much for the question. I feel that, for any autosomal recessive disorder and particularly thalassemia is the focus today. And so all the obstetricians, they should know that, we can do a genetic testing or a prenatal testing in the baby only when the genetic mutations have been characterized in the couple. So that is foremost. Or if we have a previous child, we have to do genetic testing of the previous child. If the previous child is not there, we must do the genetic testing for the couple. We must have the mutations. We have to characterize the gene mutations. Only then we can proceed with the fetal testing, as also was highlighted by Dr. Vandana. This is the most important message, I feel, that, that before referring any patient for a prenatal testing, before even counseling a patient for prenatal testing, we should, either they should order a genetic test or they should take help of someone who knows that, which test to order particularly. And then the genetic mutations must be characterized. We cannot do prenatal testing on the baby by doing a hemoglobin or an HPLC, because in case of thalassemia, that's also, a lot of times, the doctors think that, since we've characterized the HbA2 in the couple, maybe we can do the same test in the baby. So we cannot do that. So it has to be either preconception when planning a pregnancy, ideally, we do preconception testing, and then, we characterize the mutations, and then screen, and then counsel the couple accordingly. Or it has to be done early in pregnancy, as early as possible, because the ideal time for doing a prenatal testing for single gene disorders will be from 11 to 13 weeks by a chorionic villus sampling, by which, we take a biopsy of the chorionic villus, in which the fetal DNA is then separated from the maternal DNA, and then the fetal DNA can be tested for the same mutations that we have characterized in the couple, to look for whether the baby has inherited both the mutations, or the baby has inherited one mutation or no mutation. So only in case where the baby has inherited both the mutations is the concern for us that the baby will be affected. Now, also, before an IVF procedure, definitely if the couple has been found to be a carrier, then of thalassemia or of any other autosomal recessive disorder, we have an option of a pre-implantation genetic diagnosis, wherein, the embryos can be tested, again, with the help of genetic mutation characterization. We can do it. And of course, the couple also has the option of using the donor sperm and or oocyte, because we know that a genetic condition of autosomal recessive type will occur in the baby, in the fetus, only if the mutations from both the parents will come by means of the sperm and the egg. So that is another option which is available to the couple, that, either they can use a donor gamete, or they can choose to, a lot of couples, they should be given the option that even after knowing the risk of the genetic disease, if they want to continue with the pregnancy and do nothing about it.
Yeah, it's very important for obstetricians to know. And we have a mushrooming of IVF centers. So I was once referred, a patient where they had a donor sperm, and then after the conception they wanted me to do CVS, because they didn't know whether the sperm donor was thalassemia, was a carrier of thalassemia minor. So we have to be very, very sure about when we should get the couples tested, so that's so as to avoid confusions later on. So it's very, very important. So with this theoretical background, I'm sure now we can manage cases. So the first case is a 25-year-old gravida 2 with a pregnancy of 8 weeks. Previous child has thalassemia major. I think, Aarti, by now people know already what to do.
Exactly. The couple is under stress because of previous thalassemia major child, because they must be going for blood transfusion and iron chelation therapies regularly, and the growth also suffers. So before planning, they have already planned, but I'm sure we have to test both the partners for their HPLC status. And in this case, either both of them are thalassemia traits, or one of them has the disease and another one is a trait. So we should offer testing for this present pregnancy, and at 8 weeks, I would suggest them to go for CVS at around 11 weeks to rule out the possibility of thalassemia, because even if both are carriers, there are 25% chances that the baby may be a thal major. So we have to counsel the parents to, at this stage, 8 weeks, to go for CVS and get the baby tested. And if they present this, we have already discussed in previous slides also, that there are 25% chances of having full-blown disease, 25% chances of having normal disease. So I'm sure this couple can be easily counseled for the testing of present pregnancy. And if it is a positive case, then we will be suggesting termination. Otherwise, the couple can continue the pregnancy. And for CVS, we have to refer them to a good genetic testing center. And we have standardized centers all over now. That way we are lucky. And at the same time, If mother is carrier, then she'll be having only mild to moderate anemia. But if mother, we get to see very few actually thalassemia major mothers getting pregnant. So it's one full topic which we all have to understand and learn, because hopefully now we'll be seeing more and more patients for that. And regarding HLA typing also, this is very important because this helps in future treatment of the baby.
Thank you, Aarti. I just added, this HLA typing because recently I was in another panel discussion where people were talking about cord blood collection of, after doing CVS, the blood, this child is normal. So could it be a possible donor for the previous affected child? Yes. So after birth, if you come to know that that child is not matching, HLA is not matching, then at AIMS, we used to do, HLA typing along with the CVS. So these are just general, you don't have to know the details, but just remember that obstetricians should remember that you cannot do the CVS the next day. You have to refer. This is when you should refer immediately to the fetal medicine specialist who will do the needful. Your job is to then manage the anemia of the patient. Now, so this is the other case so a 30-year-old primary comes with the anemia. She doesn't have family history of thalassemia major. So what investigations to do? We already discussed that you need to do a thalassemia minor. In fact, when we were undergraduates, we were taught that after giving iron, if she does not respond, you have to think about thalassemia. Nowadays, it's not like that. You immediately screen everybody for thalassemia, and she turns out to be a thalassemia minor. So what do we do next, Dr. Vandana?
So once we have decided that this particular lady, she is a thalassemia minor, and there is no other cause for the anemia, like we've seen a microcytic hypochromia like picture, there's no iron deficiency as seen in her testing. So we've got the HPLC report, and that's got a high HbA2. We check the husband, then we do an electrophoresis for the husband to see if the husband is a carrier, right? The other point I want to emphasize is that the minute you understand that both the parents or the husband and the wife or the couple are carriers, we should immediately start the advent of the mutation testing. We should not wait further, because what we've noticed is sometimes the basic caregiver will wait till 11 weeks or 12 weeks, not do the mutation. Sometimes, most of the times, they will not do the mutation testing before, and the patients are referred directly at 12 weeks or so, or the call comes at 11 to 12 weeks only for the CVS. So understand that sometimes the mutation testing may take long because of logistics. Most people have common mutations, maybe 95% of the couples where the report might come early, but sometimes you can hit a wall where the mutation is uncommon, where you need to do sequencing for one of the partners. And by the time the baby is already 12 weeks old, we do not have answers to give to the parents, because we have not yet found the mutations. So the minute you realize in early pregnancy that you are looking at carriers, please do the mutation testing for the thalassemia immediately. We have 5 common mutations, 4 or 5 in North India, which we know of. And nowadays screening is the beta globin gene screening.
Yeah. So I think for the obstetricians, it is better that they just know that refer to the fetal medicine specialist.
Yeah.
Okay, the husband luckily is not a carrier, but she's anemic, and at 34 weeks, her hemoglobin is so low. So how to manage? Can we give a parental iron?
I think we've had this discussion before. So Dr. Arora was quite vehement about it, that do not deny iron to pregnant women. So once she has hit the 3rd trimester, and I assume that she's been given oral iron before, she's not responded for whatever reasons, and we've rechecked her, and her saturation levels are still low. I don't see why we can't even give her parenteral iron now if she has deficiency.
What would you say, Latika?
This patient, I'd like to check her serum iron and ferritin levels.
Yeah.
So we can, if a lot of times we see these thal minors whose ferritin is less than 10. So in that condition, you can go ahead and give.
Yeah, we can. But generally, we would like to avoid parenteral iron. It's better that you give blood. You should resort to blood transfusions sooner than, especially in labor. If you find a thalassemia Of course, by then you cannot have certainly give parenteral. But the general rule is that, they are already having a lot of iron. They already are sometimes overloaded because of the...
Unless we really diagnose an iron deficiency, we should
yeah,
give iron.
certainly,
If we do
certainly.
find iron deficiency.
And the other thing that I'm sure you would say is that in labor, if you find a woman with severe anemia, we said we have to give blood. And that's, we resort to blood transfusions much earlier than in a normal woman. Yeah, Dr. Chadda, you want to add?
Yeah, correctly so. So if we find that the hemoglobin has dropped below 7 or so, and the iron studies are showing that there's no iron deficiency anemia, then we should liberally go in and transfuse her.
Yeah, because it's going so low, I'm sure there is some iron deficiency anemia, and so she needs both. Folic acid certainly is not a contraindication, but parenteral iron, there is still a lot of controversy. Yeah, so we'll go on to the next case, which is another autosomal recessive disorder, and this is a case of sickle cell anemia who comes at 36 weeks with acute pain abdomen. You would think of labor, but then the uterus is relaxed and there are no cervical changes. So what is this complication? Is it a complication of the sickle cell disease, doctor?
Yes, ma'am. We, since this patient has sickle cell disease, we need to keep the sickle cell crisis in our mind while evaluating her. Or commonly, we also call it as an acute painful episode. And then, conditions like dehydration, infections, hypoxia, and very cold temperature, they can precipitate this. So this is a sickle cell crisis, and we need to rule out all these conditions. And immediate resuscitation with IV fluids. If there's an infection, we need to rule that out, give IV antibiotics, urine routine and culture, get an ultrasound done to rule out infection in the kidneys. We might require to scan the lungs, or maybe probably get an X-ray to rule out chest infection. So that needs to be done. And for the pain, it's important to treat the pain with analgesics. But since she is beyond 32 weeks, it's not very safe to give NSAIDs because they might cause premature closure of the ductus arteriosus. So opioids would be a safer option for this patient.
Yeah, so they really need to have. Now these sickle cell anemic patients are also, very at high risk of PIH. So would you like to start them on prophylactic aspirin, low molecular weight heparin, and what is your take on blood transfusions?
Yes, ma'am. Low dose aspirin should be started. Ma'am, low dose aspirin should be started routinely in all patients with disease from the first time, from the late first trimester, like from 14 weeks. And if supposing these patients require hospital admission for some obstetric indication, in that condition, you can start the low molecular weight heparin as well. Blood transfusions may be required to reduce blood viscosity and decrease the disease symptoms and obviously anemia. So we need to keep a low threshold for blood transfusions there.
Yeah, this is one condition where, anemia, because the blood is sickle cell, and especially when there's a crisis, then blood transfusion is more useful, most useful. So we have a very low threshold for blood transfusion with normal blood in cases of sickle cell disease. Okay, so this is another condition which we had talked about, which is an autosomal recessive condition. So Dr. she's there. The non-pregnant 20-year-old woman with previous female child, having congenital adrenal hyperplasia, condition where there is sexual ambiguity and adrenal changes because of the adrenals. So you have female fetus having masculine changes. So how do you counsel? She's come for pre-pregnancy counseling. Her friend, previous family child, having congenital, how would you counsel this case?
So, ma'am, in this case, we have to take history of steroid intake, a non-pregnant. Okay, so because she must have taken some steroids in the previous pregnancy, that would have.
No, this is a case of congenital adrenal hyperplasia.
Yeah.
So it's an autosomal recessive condition.
So her first baby had congenital adrenal hyperplasia. So this time we have to counsel her that if she's on some drugs for any reason, we have to find out, we have to check what drugs she's having. And if there is any drug which is the cause of CH in previous pregnancy, we have to stop that.
The CH is actually a genetic disease now.
Yeah.
So there is a 25% chance of this child of this next child that she's going to have will have the condition, and especially it is dangerous if the fetus is female, because in that case there will be masculinization.
Yeah.
So, so CVS was done, and it showed a female affected fetus. So basically, you normally start these mothers on corticosteroids so that it will suppress the fetal adrenals and then prevent adrenalization or masculinization of the female fetus. So obstetricians need to know about how to manage a pregnant woman who is on steroids, even if it is very low dose. So when should the obstetrician, I mean, what are the things that the obstetrician should know when a pregnant woman is on steroids? What could be the complications of steroids?
Ma'am, in the first trimester, like they should not be given high doses of steroids. We should know that if it is unless it's very, very
Actually,
important.
these cases, you know, we start them on steroids right from 6 weeks.
Okay.
So that you prevent the masculinization, we have to start. So the obstetrician has to know about what could be the... Yes, Dr. Vandana Chadha, you're saying something?
Ma'am, there are some case reports of cleft palate, etc., reported with steroids first trimester, but more or less they are safe. And later on, there is a high risk of gestational diabetes. That is something we worry about, and overall high risk of premature rupture of membranes and the associated complications of that. But I think the most important thing which we worry about is diabetes, because most of these women end up with GDM with our ethnic background.
Yes.
Very common in our sort of.
And if you're doing a cesarean or doing anything, you know, which causes stress, you will need to cover it with higher dose of steroids. Because if the CVS shows a female affected fetus, you need to put the mother on steroids so that the steroids, the corticosteroid will suppress the fetal adrenals and prevent the masculinization, virilization of this fetus. But invariably, these couples will terminate the pregnancy. What is your experience?
Yeah, it's very hard to...
My question is, like, if we do the CVS at 11 weeks, then how would you plan to start the steroids early in these patients?
You have to start the steroid empirically, because if it is a female child, this is what is the routine. We start as, because it's by that time that you do CVS, you know, the female sex, because the female sex will be formed and there will be virilization starting. So you need to start as early as 6 to 7 weeks of gestation.
But ma'am, even the female child would be known by 11 to 12 weeks, like as Vanna would agree. Before that, it may, to see if it is a male or female.
No, you don't see.
Yeah. So
you don't see. You empirically start.
For all fetuses.
I think you know, these type of cases with previous history of a child with congenital adrenal hyperplasia should be referred to the fetal medicine specialist, who will know that these patients should be started, when to start on steroids, when to do CVS. Do you need to stop the steroids before doing a CVS? Do you need to stop the steroids before doing amniocentesis, you know, in case she comes late? So there are so many questions. I don't want to go into the details of fetal medicine expertise here, because we are talking to obstetricians. So obstetricians basically need to know that as soon as a pregnant woman comes, a non-pregnant woman comes with previous child with adrenal hyperplasia, she should be referred. She should be referred to the fetal medicine specialist. So early referrals, you know, I have always been dealing with RH Ashkenazation, and I've been crying for the last 30 years. Send them before hydrops develops. So these also are things like, send them to the fetal medicine specialist before becoming next time pregnant. That's why, because she needs to be started steroids very early. And that is not for anything else, but to
clarify this point here, that both male and female children can be affected. It is an autosomal recessive condition. It's just that the female fetus is prone to virilization, the male fetus is not. So empirically, you have to start steroids, and then if you prenatally diagnose the condition, I think the prerogative of the parents whether to continue or not. I guess it's a severe morbid condition. So that
is not very dangerous, but you know, women in India, because MTP is so common, so easily, and as it is, they have this bias against female fetuses, though we are quite safe from the point of the PCP entity, because anything which affects the sex conditions, you can always tell, but we don't tell the parents that it is a female fetus, but we just start them on steroids. And they invariably know that you're starting because it's a female fetus.
Sometimes you can have salt wasting and all, but I think
yeah, I'm just talking about the commoner one. So salt wasting, of course, those are quite dangerous, and if you find it affected, it's better that you terminate.
Thank you.
Anyone wants to add anything? Is Mandakini here? Anybody? Okay. So basically, it's caused by decreased enzyme, and we start dexamethasone should be started before the organogenesis of the genital tracts, so that the female fetus may not be affected. And then we do prenatal diagnosis. We can do Corinne-Wheeler sampling directly, but if you want to do the enzymatic levels from the amniotic fluid, you have to stop steroids for 1 week. And as everyone said, that the risk of steroids, PIH, bloating, sensation, risk of surgery, all these are there, which you have to take over.
Yeah.
Okay. Dr. Divya, this is another autosomal recessive condition, cystic fibrosis, which is not very uncommon. It's a newly married woman, and she had a friend who just had a child with cystic fibrosis. So she is very scared and wants to, test herself. Is it indicated?
So the simple answer will be that, it's not really indicated, because the population risk of having anyone to be a carrier for cystic fibrosis in India is low. It's not very high.
But she got very scared because her friend has now a child who's in the ventilator.
Yes, correct. So since her friend has, so now it doesn't put her as, in the increased risk category, obviously.
But her friend also did not have any symptoms, that's why she's so scared.
Correct. So, here I would just like to introduce the concept of general carrier screening for the asymptomatic couples. If she wants to test herself, then it can be done as a part of a carrier screening panel that we now advocate, and now ACOG also advocates, which is a general panel of genes for severe autosomal recessive conditions, in which, without any family history, without any increased risk for the couples, if they want to get themselves tested for any genetic conditions which are severe and not treatable, then they can get themselves tested. Now, there are various types of panels which can be discussed with a geneticist or a fetal medicine specialist, but it can be done. And yes.
Yeah, for example, thalassemia. We talked about thalassemia. So usually there is no family history, but we screen. And if somebody is really so scared and insistent, then there's no harm screening, isn't it?
Absolutely.
Because, cystic fibrosis is quite a, very troublesome disease and can even be fatal. So now she wants to know about her friend, what to advise her.
So, of course, if like any other autosomal recessive condition, the genetic mutations, the cystic fibrosis in the baby, the affected child, needs to be confirmed by a genetic analysis. And once the gene mutations in the CFTR gene have been characterized in the family by testing of the proband, then the friend should be counseled that they can prevent the disease in the next pregnancy by doing a prenatal genetic testing at 11.
So they need to do testing for themselves also.
Yes.
Yes. So that's how it should be: prenatal counseling and then prenatal diagnosis, as you have just said. So we really need to prevent genetic disorders by screening, and we do have newborn screening. But newborn screening for all these conditions is too late, isn't it? So we need to shift from newborn screening to prenatal screening, maybe pre-pregnancy screening, and thus prevent the birth of a child with any recessive disorder. So I can see that we still have a lot of participants, and I'm sure they would be having a lot of queries. So we could go on to the chat box. Shall I do that, or anybody else would be interested?
I'll quickly read the questions because there are some queries. Thank you, ma'am. It was a very interesting panel, and everyone got a lot of take-home messages from the discussion. I'm very sure about it. Yeah. So Dr. Anita Rajoria has a question, is repeated anencephaly in any way related to consanguinity? She had a patient at 28 weeks who came for ANC first time, and she had a similar history in last pregnancy, and there is history of consanguinity. Although it's, it's very sorry to see that anencephaly was being picked up at 28 weeks, because mostly anencephaly can be picked up at 11 to 12 weeks ultrasound when we send them for their first screening ultrasound. So she wants to know about the role of consanguinity in repeated anencephaly in fetus.
So I think consanguinity was Latika's. Yes, Dr. Latika.
What are your views on anencephaly? Even I have seen a patient who had 3 consecutive anencephalic babies. Yeah, but the 4th one was normal.
Ma'am, initially, anencephaly, we would like to test for the methyl tetrahydrofolate receptor mutations would be this thing, and again, autosomal recessive condition definitely would be a
yeah, but this anencephaly is one of the commonest CNS malformations. The recurrence risk we always talk about, that if the first one is anencephaly, the second time is a 5%, previous 2, then it's 10%. So the risk increases. So Dr. Rajuri, we have to do actually put her on prophylactic folic acid, do the blood sugars. And certainly, now that she's had so many, we could think about a genetic condition. So please refer her to a geneticist.
Thank you.
At your level, you should do the blood sugars and put her on a higher dose of folic acid.
Yes, yeah, for her next pregnancy. So Dr. Reena Ahuja, she's a senior gynecologist from Dehradun. I'm sure Dr. Deepika would know her also.
She was our resident, yeah.
Yeah, she wants to know about the elaborate management of salt-losing adrenal condition, and she's suggesting that sometimes there can be sudden unexplained IUD in cases of salt-losing condition.
Okay, so who was reading about congenital adrenal hyperplasia?
Vanna, what is your experience? Thankfully, I have not seen a case of congenital adrenal hyperplasia so far. I have seen a lot of muscular dystrophies and anencephalies, but maybe I was lucky. Yeah.
So I think it's the neonatal period that will experience the symptoms, but the pediatrician here will be the better person to answer. I have not experienced IUD because of salt losing condition myself, but I think in the early neonatal period, you'll get the clinical scenario where there could be adrenal crisis because of the low aldosterone levels. And so
Yes, ma'am. So the salt wasting happens in the neonate. In the pregnancy, we usually wouldn't get a scenario where there is a salt wasting phenotype. The salt wasting phenotype manifests in the neonate, and the management in pregnancy is essentially what we enlisted: antenatal steroids and the prenatal testing. So that is what the antenatal management would entail. And it is, other than that, the salt wasting is managed in a neonate by giving the steroids, the glucocorticoids as well as the mineralocorticoids.
Thank you.
Yeah, what was her question exactly?
So her question
it doesn't usually cause IUD. But so as Dr. Divya said, it is mainly they'll end up with sudden collapse, after birth. So when you're looking for these, then you find that all the electrolytes are bad. And so you have to urgently manage these with corticosteroids and mineralocorticoids.
There is a good question. One anonymous attendee wants to ask you, what are the tests to avoid autism in the newborn?
Yeah, anybody would like to answer that?
Like if a lady has one autism baby and I refer her to Vandana, she wants to be very careful before planning her next pregnancy.
Yeah, I think Dr. Divya has just mentioned that we have panels now where we can do a sequencing for both the parents and look at carrier status of parents for various genes. So if we find a mutation which predisposes the fetus to perhaps an autistic condition because both the parents are carriers of a particular condition, then that could help us in the genetic scenario. Other than that, I don't think we know the causes of autism for, we got diagnosed every autism. It's most of them are, some of them might be unknown. So that's something which the risk of that will stay for anybody and everybody, as a risk of cerebral palsy stays for labor related conditions. You cannot avoid or change that completely. There'll always be a risk in labor for CP. Similarly, I think autism is not something I can give you 100% surety that it'll never.
Yeah. So basically, the pediatrician who's looking after the geneticist is looking after the autistic child will have worked up that child and tell us whether, it is a condition that has been diagnosed, because most of the times you don't find any cause for the autism. So if you can't find a cause, you cannot do prenatal diagnosis. But if you do find a cause, which is very, very rare, then we have had cases where we have done CVS for that particular reason, for that particular mutation, which has probably caused the autism. So the answer would be a very case-to-case basis. You can't give a blanket statement that you cannot do prenatal diagnosis, or a blanket statement that you can do prenatal diagnosis. So it is all based on the case, how much the previous child has been worked up, and whether a cause has been found.
So here they have a previous child, or it's just she wants to prevent.
It was just a question, but I had kept a scenario because it has happened with me also. Like one autistic child, the couple is so scared to plan second one, and
so then
they
is somebody looking after that autistic child? A geneticist has seen.
So a very interesting comment by Dr. Mandakini. Waha, madam, Deepika madam, you are there. I'm very, very thankful to you. Dr. Mandakini, we have the last question for you now, because we have been bombarding Dr. Deka with all our queries. So this is the last question of the session, because we are already late. So Dr. Pratima wants to know that a congenital adrenal hyperplasia girl on lifelong Visolon, when she goes on to conceive in later life, what measures should be taken, preconceptional counseling, and any specific tests to be done during antenatal period? Mandakini ma'am, we want to see you if you are with us.
Yeah, I am there.
Yes, ma'am.
Right there with you. Enjoyed the panel. First thing is this couple, who is this girl who she herself has got late onset congenital adrenal hyperplasia.
So ma'am, can stop sharing the slide, please, so that we can see everyone. Thank you, ma'am.
Wait, how do I do that?
Yeah, you stop sharing, then we'll be able to
stop sharing. Okay. Yeah, got it.
Thank you.
Yeah, thank you. That girl must be on glucocorticoids and mineralocorticoids. I happened to manage 3 of them, and they became pregnant. First is we know that congenital adrenal hyperplasia is a autosomal recessive condition. So the female is affected. That means she has got 2 mutations. That means and is causing congenital adrenal hyperplasia. Now we need to see if her husband is a carrier of congenital adrenal hyperplasia or not, and which may not be manifesting anything. So we test the couple. If he is absolutely normal, not a carrier of congenital adrenal hyperplasia, the baby will be all the babies will be carrier. And the scenario of autosomal recessive condition has already been explained. So, and the risk of steroid being taken by the women, like we monitor them more frequently with even including sodium potassium because of the pregnancy changes, and steroid we can give. See, in SLE patients, we give up to 40 milligram per day. So we can give glucocorticoids if the requirement is more. So we intermittently, almost the ideal time is once every trimester, but sometimes we do more frequently. They are corticosteroid and stimulator corticosteroid, and then give them the steroid and manage their pregnancy. That is how congenital adrenal hyperplasia is little difficult. That what we saw previously is a fetus being tested. You tell me if a female fetus is there and is affected, and this female is going to be having medicines lifelong, none of our couple will continue this pregnancy.
Yes.
So if my experience is that if we are doing an antenatal diagnosis for congenital adrenal hyperplasia, after explaining everything, then no couple will continue a pregnancy which is affected with congenital adrenal hyperplasia, knowing that this baby will require glucocorticoids and mineralocorticoids throughout their life. So this giving dexamethasone practically is like initial days we used to give, but with the advent of prenatal diagnosis, most of the patient couple are not willing for it and opting for prenatal diagnosis and termination of pregnancy if the fetus is affected. Thank you so much.
Could I just add, ma'am? Sorry for joining late.
Yeah.
Sorry. So like ma'am correctly said, it's no more dependent on the sex of the fetus. And also, even if we do a prenatal diagnosis and find the gene mutation, this being a pseudo gene does not tell us about the severity of problem that's going to happen. So that's another dilemma in counseling that we would have while doing a genetic counseling of this couple. But like ma'am said, I am also yet to find a couple that has continued the pregnancy once a CVS has been done for the mutation. Fortunately, the mutation is found in 95% of the congenital adrenal hyperplasias. That's a very good number to pick it up. And yes, most of them do terminate the pregnancy. Thank you, ma'am.
Most of them terminate, but I think Latika would remember. We've had lots of cases
Yeah.
who have continued.
Initially,
who have continued.
Yeah. Yes.
And the question that was said was, what will be the problem? See, a lot of my CH patients have conceived, had normal deliveries.
Yes.
So we probably have to tell them about the morbidities and the lifelong supplementations.
No, it's not a very high dose that they need to take. And we have the gynae endocrine clinic, and their follow-up there. It's very common. Very, very common for patients to be really having CH and continuing life normally, having families, children.
Yes.
With a good follow-up and if they understand the compliance of the...
If I have seen 3 patients conceiving, so everybody must have seen.
Yeah, in AIMS we have the clinic, the endocrine clinic. So we really see a gynae endocrine clinic and we really see a lot of patients.
So the non-classic variants are very common. So only in the classic type, the severity.
It will be the simple classic.
The non-classic ones will survive and they will just return to normal lives.
They won't even.
Only the salt wasting varieties are the ones which are have a very high morbidity. The others can be easily managed.
Yeah. Thank you. Final word from Dr. Manish and Mandakini ma'am for the lovely webinar, and all have learned a lot.
I had a basic doubt, if I may have the opportunity of discussing with Dr. Dekha. Actually, 2 months back, we had this mother who had a baby with HAL major. So she came to us for testing and also HLA typing because she was educated and she knew about stem cells. So then we did the CVS. One of the prior to doing the CVS, she had told us she wanted the HLA typing to be done. Now, unfortunately, this baby turned out to be THAL major. So we did an MTP, but we had a discussion with her that she also wanted an MTP, the HLA didn't match. So would that be an ethical ground to do a termination if the baby is THAL carrier, but the HLA is not matching?
Yeah, so I know it is not, it doesn't sound ethical, but this is the trend nowadays.
Yes.
The educated class especially, they not only just want to do thalassemia testing, they also want to do the HLA because their major purpose of conceiving is the previous child should be treated. And if they don't get bone marrow, then they depend upon the to-be sibling to be the donor. So we were even discussing the other day that since termination of pregnancy is so easy, literally on demand, it is not ethical, but you cannot stop.
Yes, ma'am.
They will just use another excuse like we didn't want this baby because of this.
So in India, there is any regulation, there is any there are any fixed guidelines regards to this. In a lot of other countries, there are fixed guidelines as
in
to
India, it's literally, I mean, actually on demand. Anyone will say it's failure of contraceptive. You can just read in between the lines and do what you want. That's the sad part.
Yeah.
If I'll just add, in case one wants to get an MTP done and one wants to use the fetal indication, which says that if the baby were born, it would have such a handicap so as to make his physical or mental life difficult.
Yeah.
If you want to use this indication and perform an MTP, which as on today is only up to 20 weeks, then you have to resort to a confirmatory test, which is either an amniocentesis or a CVS. Screening tests would not qualify you to use that indication, but all the indications are available till 20 weeks. So as Deepika ma'am correctly said, anybody can put failure of contraception till 20 weeks and do an MTP. That is not the issue. The point which I was telling, and again the point is for all of you to follow, is that Foxy is it is a 40,000 members association with, I know, members practicing in all nooks and corners, plus lot of medical colleges. So maybe these tests which we are discussing. So my request is to have a protocol which says the following things are recommended and the following things are offered after counseling. Now put it in these two categories. Now what happens is, so if I counsel somebody and offer a test and then that person does not do that test, then I am saved if there's a problem. So I have to counsel and offer a particular test, and some tests may be recommended. So I understand at Foxy level, maybe they would not, jump and recommend everything at first go. But let us divide it into recommended investigations and counseling and offered investigations. So there are cases which we face where, counseling and offered investigations were not done. And then it is easy for us, from another point of view, I am talking. So when in case there is a protocol made, I just urge and request everybody that have it in these two categories, so things become very easy.
I think so. And now that we have Mandakini here, who is the chairman of the Genetic and Fetal Medicine Committee, we could do that. And the last book that I wrote, Introduction to Genetics, was 10 years back when I was the committee chairperson. So it's time for you to write the next edition.
Thank you, ma'am. Thank you so much.
No, then we can introduce all these things,
Yeah.
If it goes in a Foxy book, that these are the recommendations, these are the things that you should counsel, then we can go by those guidelines. So I think you should, the quickest thing would be to write a book.
A good Foxy focus, because
Foxy focus will be too small, but we have a Foxy book, the Introduction to Genetics and Fetal Medicine. Dr. Kamini Rao had written the first edition. I had edited the second edition. So that was 10 years back, 2010. So now I think you can do that, Mandakini.
Oh,
and
yes.
put it on the ICOG online website. That will be.
Yeah, Dr. Manish will be my this thing. So now today probably like that's this thing.
He's your legal advisor.
Yeah, and
anytime. Mandakini ma'am, आपके साथ काम करने मिल जाए तो जन्म सफल, और क्या चाहिए?
नहीं, it's not that. It's good because genetics is fast moving. Now everything, and we need to understand it. That's this thing is my effort is to make people at least understand what is it. And it is easily, it can be like.
Yeah, that's what, in the beginning only I said that we should not talk about too much details. We talk about genetics for the obstetrician.
Practical, yes. Practical for the
how much they should know.
Day-to-day practice.
They should know, they don't have to know details, because then they can always refer. I still remember Ashok Khurana used to say, like when I started fetal medicine 35 years back, that it's easier for obstetricians to refer to Dr. Dekar than to do the counseling themselves.
True.
But now you see, everybody needs to know a little bit about genetics. So basics of genetics, every obstetrician should know.
Thank you, Dr. Dekar, for a very useful and academically interactive webinar. Big thanks to Dr. Mandakini for motivating it to make a fetal and Foxy committee webinar. And thanks, Dr. Manish, sir. A formal thank you, Pooja, for joining late, although Vandana, your talk was very interesting. Thank you, Radhika. A quick note of formal thanks from you. Dr. Sujata, it's always a pleasure to interact with you. Thanks. Radhika, a formal note.
I'd like to thank everybody for joining in. I'd just like to present ma'am's new CV. I'm really apologetic to ma'am for the inconvenience. This is ma'am's newest CV. There is apologies, ma'am. I'd like to thank everyone for being here. It is a great opportunity for Dehradun Society to have such stalwarts and such experienced seniors with us. And you've given us excellent take-home messages. Thank you, Deepika ma'am, Mandakini ma'am. Thank you, Manish sir. Thank you so much, Archana ma'am, for gracing the occasion. Lovely speakers, Dr. Arora, Dr. Chadda, an excellent panel and a very gripping and intriguing panel, I must say, Deepika ma'am. We've all, the number of participants did not, disappear till the end. We still managed a great audience, and thank you so much for your wise words. Thank you, everybody. The panelists were great. And Aarti ma'am, thank you so much for organizing the webinar and making it a great success. Thank you, everyone. Thank you.
Thanks to Walter Bushnell for a very, very smooth streaming and making it happen. Thank you.
Thank you, Aarti ma'am. This is Ranjit ma'am, marketing head with Walter Bushnell.
Can I have 1 minute, please?
Yes,
Mr.
please.
Ranjit, please send me the participant list.
Okay, ma'am. Sure. I will be sending across, but tomorrow morning you'll be getting it, ma'am.
Okay, thank you.
So, ma'am, wishing you all. So, Walter Bushnell always stands committed with such kind of scientific feast as always, ma'am. So, looking forward for long-term association with you as always, ma'am. Thank you. It was a nice, informative webinar. Thank you.
Thank you. Stay safe. Stay healthy.
And Dr. Mandakini.
Thank you so much.
Fruitful evening. Thank you, ma'am. Thanks.
Thank you. Thank you, everyone.
All of the delegates, stay healthy, stay safe, ma'am. Thank you. All the very best.
Thanks.